Treating Persistent or Chronic ITP, Current Care, Future Potential 2022. The objectives of this activity are: discuss treatment considerations for persistent or chronic ITP, evaluate the clinical information of approved and emerging therapies for persistent or chronic ITP, develop individualized treatment strategies for patients with persistent or chronic ITP.
Thank you for joining us today on this discussion of treating persistent and chronic ITP. The content of this slide was developed by myself, Cindy Neunert, Dr. Hanny Al-Samkarim, and Dr. Adam Cuker. So immune thrombocytopenia, or ITP, is an autoimmune disorder that's defined as having an isolated thrombocytopenia based on a platelet count less than 100,000 in the absence of any other cause or disorder that may be associated with a low platelet count. And even in our modern times, it really truly remains a diagnosis of exclusion. There's an increased risk of bleeding associated with the low platelet count, but it's important to note that bleeding is very heterogeneous and not all patients will present with the same degree of bleeding, even if they have exactly the same platelet count. ITP can be classified as either primary or secondary, and as shown here, the majority of cases, almost 80%, will be primary, with then some associated secondary ITP related to the condition shown here. With regards to the epidemiology, ITP has a bimodal distribution with a common occurrence in the toddler age group and then again in older individuals. There's a more predominance of males, particularly in the young toddler group and in the older age group. Our understanding of the pathophysiology of ITP has advanced significantly over the years. We first knew that we could appreciate that there was antibody production that was coating the platelets, and these antibodies were interacting with macrophages via the Fc receptors in the spleen, and then we're getting removed and we're not recirculating. And this was the basic concept of ITP, leading to increased platelet destruction. We've now further become to understand, however, that these antibodies also interact with receptors on the surface of the megakaryocytes, resulting in decreased platelet production, as well as the role for T-cell mediated direct cytotoxicity. When we think about treating ITP and our goals of treatment, there's several different ways for us to consider our treatment approach. The first is treatment of hemorrhagic symptoms via prompt increase in the platelet count. This is always our first and foremost treatment goal in a patient who might present with severe bleeding. But we're also oftentimes trying to prevent subsequent hemorrhage from occurring, even if a patient doesn't have significant bleeding at the time of diagnosis. And there's a lot of work trying to be done to understand what are some of the additional potential risk factors that might lead to subsequent hemorrhage. And certainly the degree of bleeding at the time of diagnosis comes into play, the patient's lifestyle, other medications, other comorbidities that might alter their risk. We also spend a lot of time thinking about what's the quality of life of our patient. How can we improve their quality of life, whether it's related to activities that they want to be in, or a lot of patients report to us that they feel very fatigued and very tired, and how can we make that better? And it's oftentimes a discussion. We're trying to really understand what's the patient's comfort level with both the disease, but then also the treatments that we're using, because we never want to engage in a treatment that actually makes the patient feel worse than how they felt when they were just living with ITP. And then we're also always trying to achieve the goal of providing either a medication-free response or a remission for our patients. When we break down our categories of treatments, we can often sometimes think about them in terms of how long our patient has had ITP. So here we see newly diagnosed patients is from the time of diagnosis to 3 months, persistent ITP defined as 3 to 12 months, and then patients with chronic disease as being greater than 12 months. For the sake of this discussion, we're really going to be focused on those drugs that were designed and brought into development for patients with either persistent or chronic ITP.
This figure represents the conventional treatment paradigm for ITP. And let's start at the top with the goal. It's important to emphasize that the goal of treatment in ITP is not to normalize the platelet count, but to achieve and maintain a safe hemostatic platelet count while minimizing treatment-related morbidity. And for most patients in most situations, a platelet count of greater than 20 to 30,000 is a safe hemostatic platelet count. So if the patient's platelet count is, for example, greater than 50, treatment would rarely be required, and we can usually manage patients in this situation with observation alone. On the other hand, if the platelet count is below that 20 to 30,000 threshold, we typically resort to first-line therapy. And the backbone of first-line therapy is corticosteroids, supplemented as needed with anti-D or IVIG. Now, some patients will respond to first-line therapy and maintain that response after the first-line therapy is tapered. And so if they achieve a stable platelet count above 30 to 50,000, we can observe them without giving additional treatment. But unfortunately, at least in adults, primary ITP tends to assume a chronic course. And so most patients, including those that respond to first-line therapy, will relapse after first-line therapy is tapered and will need to go on to second-line treatment to try to achieve a platelet count that is maintained above 20 to 30,000. And the standard second-line treatment options, and we'll be discussing these in much more detail today, include Rituximab, the thrombopoietin receptor agonists, splenectomy, and Fostamatinib. And it's the relatively rare patient who does not respond to or is unable to tolerate any of these second-line therapies for whom we need to use third-line treatment. And third-line treatments include a host of immunosuppressive agents, including azathioprine, cyclosporin, cyclophosphamide, danazol, dapsone, mycophenolate mofetil, and vinca alkaloids. So for most of this talk, we are going to talk about the various second-line treatment options, the pros and cons of these options, and how to choose the best treatment for your patient based on the patient's preferences and values. And to illustrate how this is done, I'd like to start with a case. This is the case of a 28-year-old female. She has no significant past medical history. Her only medication is an oral contraceptive pill. And she presents with easy bruising and gingival bleeding with flossing for the last week. 1 week ago, she had an unusually heavy menstrual period. So you get labs. Her white count and her hemoglobin are normal, but her platelet count is markedly reduced at 18. Her chemistries and liver function tests are within normal limits, as are her INR and APTT. So if you were the hematologist, the next thing you would do would be to review the peripheral blood smear. In this case, the smear shows a decreased number of normal appearing platelets without clumping. The red cells and white cells are normal appearing. And so you suspect ITP and decide to initiate treatment. Which of the following is a reasonable treatment option for this patient?
This is a great case, Adam. It really highlights our first initial management of a patient with ITP as we just walked through. And I think we can even come back to what are our goals for treating this patient. She's had some bleeding in terms of having menstrual period and some gum bleeding. We also recognize that her platelet count is below the threshold that we consider for treatment of 20,000. And so really our mainstay of treatment for the patient such as this would be prednisone. With Rituximab and Hetrombopag being reserved for those patients who fail a first-line therapy. And then while IVIG is also a first-line therapy, I think it's important to kind of know that IVIG is used more in patients that have a contraindication to corticosteroids or some inability to tolerate them, and or those patients where we really need a prompt increase in the platelet count due to some sort of emergent bleeding situation. So in this case, the correct answer would be prednisone 1 milligram per kilogram per day.
So the case evolves. Just as Cindy recommended, you treat the patient with prednisone 1 milligram per kilogram per day, and she has a robust response with normalization of her platelet count after 1 week. You taper her prednisone dose over the next month, but on prednisone 10 milligrams per day, her platelet count has fallen back to 15. Which of the following is a reasonable long-term treatment option at this point?
So this again really highlights the natural course of ITP. As we mentioned, a lot of patients will end up with a refractory ITP following the discontinuation or tapering of corticosteroids. And so it's always important to have in the back of our minds what our next steps are going to be. And really, certainly going back to more prednisone or more dexamethasone isn't the right approach in the sense that that's just going to increase long-term side effects of corticosteroid exposure without any real true documented benefit to the patient. And so that's really not a long-term solution or option for patients such as this. So then we're kind of in the category of splenectomy or rituximab. And at this time, I think rituximab, 375 per meter squared weekly for 4 doses is the next reasonable step. And we can talk a little bit in our discussion about second-line therapies as to why that might be the case and be more preferable than maybe what used to historically be done, which was to go straight to a splenectomy in patients such as this. So as we've just mentioned, when we get to the stage of thinking about second-line therapy, we really have 3 kind of traditional agents that we can now look at. And our most historical is splenectomy. And splenectomy really works in its most simplest form by removing the spleen and the source of that macrophage phagocytosis of antibody-coated platelets. We then had development and introduction of rituximab, which is a CD20 monoclonal antibody that's really going down and shutting down the B cells that are responsible for antibody production. And then with the increased knowledge about the pathophysiology resulting in decreased platelet production, we have a newer category of drugs called the thrombopoietin receptor agonists that actually go to those megakaryocytes and stimulate platelet production. So we'll talk about each of these just in a touch more detail in the subsequent slides. So as I mentioned with our case, splenectomy is really historical second-line therapy. It's successful therapy, probably remission rates of about 70%. One difficulty in interpreting these remission rates, however, is that they represent data based on older cohorts of patients in which splenectomy was done much sooner in the course of the disease. So there may be some overlap with natural remissions that were going to occur in those patients regardless of splenectomy. We also don't have any predictors of response. So here we are, it's a permanent surgical procedure, and we can't really tell a patient with any good certainty whether or not they will end up being a responder or a non-responder. And most importantly, we have loss of immune protection. A little bit of this has been improved in terms of side effects with the use of vaccinations and antibiotic prophylaxis, but truly we are causing a lifelong state of an individual becoming immune compromised. And then there's some emerging data on vascular complications following splenectomy. These are mostly characterized in other hematologic disorders, such as those that have ongoing hemolysis, so the thalassemia populations, perhaps, or even hereditary spherocytosis, maybe less so in a more pure population, such as ITP without red cell hemolysis. So as I mentioned, rituximab is a monoclonal CD20 antibody. And it really showed very good early remission rates. In adults, remission rates were approximately about 60%. So very good early induction rates. However, this seems to decline over time, as you can see in this graph, with both adults and children. That really nice initial response sort of wanes over time. And 5 years out, only about 20% of patients following rituximab will remain in remission. There's also some inherent difficulty with how we use rituximab for ITP. We don't have any good dosing studies. It's possible we're overdosing. We're applying sort of regimens that have been used in chemotherapy protocols. And there is some evidence that perhaps lower dose protocols may be just as effective. It's not benign therapy. It's associated with serum sickness, infection risk, infusion reactions, and also this notion about persistent hypogammaglobulinemia, particularly in younger children exposed to rituximab, perhaps with a developing an immune system. And this is really related to younger age or perhaps some missed underlying primary immune deficiency. It also can take time to have a response to rituximab. As we pointed out in the case, it takes 4 weekly doses, and some patients may not respond immediately. So it may not be appropriate in a patient that has an acute bleeding event. While you may use it, you're also probably going to have to use other agents at the same time. And then as we pointed out in the graphs, long-term remission rates remain less than with splenectomy. So the more recent category of drugs is the thrombopoietin receptor agonists, of which there's 3 that are now currently FDA approved for ITP. Remipulstim, which is sub-Q weekly administration, Hetrombopag, which is a PO daily medication, as well as Avatrombopag, which is also a PO daily medication. They've all been shown to be effective at increasing the platelet counts in adults with ITP, with durable response rates ranging from 50 to 90%. The platelet count will typically increase by about 2 weeks, and this may be a little bit limited by the dosing nomograms and escalations that are outlined in the clinical trials. But even with the need to kind of increase or escalate, by about 2 weeks, the majority of patients will start to show some response in their platelet count. So there are some limitations to be mindful of when we use the TPO-RAs. There's difficult administration, particularly for Hetrombopag, which has dietary restrictions. It can also be associated with a transaminitis, so liver enzymes need to be carefully monitored. Fostamatinib is a sub-Q weekly injection, and for a lot of patients, this does require getting it delivered in a physician's office, so there's weekly appointments at the physician's office. And then Avatrombopag is an oral agent that sort of overcame some of the dietary restrictions of Hetrombopag. I think we also always have to think about cost, right? We're comparing these drugs, which require ongoing use, to splenectomy, a definitive therapy, as well as Rituximab, which is for infusions. And so cost analysis and cost benefit data really needs to be done to know how these all line up. And then lastly, this is not curative therapy for the majority of patients. I think there is some emerging evidence that patients may demonstrate a drug-free response following treatment use, but for the majority of patients and those that go on these therapies, they require ongoing use to maintain a response. So when we worked on the American Society of Hematology guidelines, we really tried to look at these three as a branch point decision. We realized that in clinical practice, oftentimes we're comparing all three of them side by side simultaneously and really trying to make a decision in a patient who had either persistent or chronic refractory ITP. When we worked through what was available for both the benefits, the risks, the feasibility, the application, the panel ultimately suggested Rituximab rather than splenectomy, suggested the TPOs rather than Rituximab, and then suggested either splenectomy or the TPOs. And as you can see, this doesn't lead to a nice hierarchy of decision-making, and that leads us to a little bit more of discussion and interpretation of guidelines. So in thinking through how we got here, the risks of TPOs were thought to be low with some potential benefits compared to Rituximab or splenectomy. But it was also recognized by the panel that the TPO-RAs require ongoing therapy. Again, it's not the same as comparing to two definitive treatments. Rituximab may also have benefits in certain populations, particularly young women seem to respond better to Rituximab than other subgroups of patients. Overall, the risk of Rituximab was thought to be less than splenectomy, and potentially curative therapy, or at least Rituximab may lead to several years of a drug-free response and delay splenectomy. There's also a strong desire among panel members to avoid immunosuppression, and this was even greater consideration perhaps now in the setting of COVID, really trying to avoid immunosuppression. Ultimately, though, the panel felt very strongly about avoiding splenectomy until 1 year with ITP, unless it's in the urgent setting. And this comes back to our case as to when we sort of said perhaps Rituximab would be the right option for the patient that was presented by Adam, in the sense that really we hadn't been having a long enough duration of ITP to which splenectomy would be the next step. But I think it's possible to continue to ask ourselves these questions as to when should we consider Rituximab over a TPO-RA, or when might splenectomy be the right choice for a patient? And how do we work through this? So embedded within the guidelines was a huge recognition that patient preference and other disease-modifying factors might play into our decision-making when trying to apply these guidelines directly. And so there were several branch points that were considered. The first being sort of duration of ITP. Are we in that category of 3 to 12 months or greater than 12? Because that really was the branching point at which we would think about having splenectomy as an option. Within 3 to 12 months, it really takes working through our patients' values and preferences to ascertain whether or not a TPO or Rituximab might be the right option. Beyond 12 months, again, we can sort of engage in the same decision-making, the same assessment of values and preferences in order to determine at what point might splenectomy be the right option for a patient. So we're going to continue with our case. And after discussion, she decided to undergo treatment with Rituximab. It's now 4 months later, and despite a slight increase in the platelet count initially, she's now requiring treatment again for a platelet count of 12,000. So what is our suggested next treatment for this patient? So in a patient like this, a TPO-RA now makes perfect sense. She's still early in the course of her disease, so splenectomy doesn't really make sense yet. She's already tried Rituximab, and additional courses of Rituximab may not have any benefit to her and may simply just be exposing her to significant side effects. And a particular side effect that we worry about with cumulative Rituximab exposure is the process of progressive multifocal leukoencephalopathy, or PML. And then we don't want to do watchful waiting if her platelet count is again now less than 20,000, and she is reporting some bleeding symptoms to us. So in this case, a TPO-RA is a really great next option to move on to.
Well, thanks for that review, Cindy, of the different second-line treatment options. And so let's apply some of what you taught us to a case. And so we're back to our case. It is now 18 months later. The patient had only a transient response to Rituximab. She did not respond to Hetrombopag or Romiplastim. She underwent splenectomy 3 months ago and unfortunately did not have a sustained response. She is currently on the maximum dose of Romiplastim, 10 micrograms per kilogram per week, and prednisone 20 milligrams a day, and her platelet count is still about 15. Which of the following agents is FDA approved for treatment of refractory ITP?
Well, these are certainly the cases that we all struggle with after we've already walked through our current second-line therapies that are part of the guidelines. But it is important to note that Fostamatinib was just recently FDA approved for refractory ITP patients and should be considered. I think where we position it amongst Rituximab and the TPOs, perhaps there was not enough data at the time of the guidelines, but Fostamatinib would be the only FDA approved treatment to move on to in a patient such as this. Danazol and cyclosporin fall a little bit more into third-line agents, and mycophenolate mofetil is, I think, sort of also trying to get some data out there about how to use mycophenolate mofetil, but it is not currently FDA approved for refractory patients and really would still be considered in the more third-line agent. Fostamatinib represents a new sort of category of drugs that take advantage of the fact that SYK is required for the conformational change needed in macrophages in order to have that interaction of the Fc receptor with the antibody-coated platelet. SYK is a tyrosine kinase. As mentioned, it's a regulator of phagocytosis. It induces that conformational change that is required. So in coming in to block that conformational change, ideally you are blocking the ability of a macrophage and a platelet to interact and then have phagocytosis occur. And Fostamatinib is the only SYK inhibitor that was approved. It was approved in 2018 for use in patients with chronic ITP that's been refractory to other therapies. Fostamatinib is dosed at 100 milligrams twice daily and can be increased to 150. And there were different clinical trials that have been conducted. The phase 3 clinical trial was really combining 2 randomized controlled trials and an open label extension study. And what they found was there was an overall response rate of 43% versus 14% in the placebo. What's interesting is when they looked at using this as second-line therapy, that overall response rate went up as high as 78%, likely because in this study, there was a large number of previously treated and unresponsive patients. But when you looked at just using it as second-line therapy, the response rate was much higher. The most commonly reported adverse events included diarrhea, hypertension, nausea, vomiting, dizziness, and transaminitis, all of which resolved and were managed by dose reduction or dose interruption. I will say most of the side effects that led to discontinuation of the drug in patients was the GI side effects. So this shows the pooled data from the studies. You can see here between the two studies, we have an overall and a stable response that's much higher than what was seen with placebo. When we pull those results together, it continued between both studies to show a favorable impact of Fostamatinib on overall and stable response compared to placebo. But what I would like to note is that only 18% of patients really did achieve a stable response. So I think there's still a little bit to learn about, one, the tolerability of this drug in patients, and then also the stable response over time. In the open label extension study, 17% of the patients demonstrated a stable response.
Thanks, Cindy. So just to put a bow on this case, you do end up treating the patient with Fostamatinib, 100 milligrams twice daily. She tolerates the treatment well, and after 3 weeks, her platelet count rises to 75, and you are able to successfully taper her prednisone off over the next month. A happy ending.
So we always enjoy a case when it ends well. But let's talk about, we had mentioned, Adam, we had mentioned other therapies. And I think there is a huge list of drugs that you brought up even in the beginning with the treatment paradigm that sort of fall into this third line category. And I think it's important to recognize those drugs. I think that we recognize in different areas and different places, access to drugs may be different. And so it's important to highlight all the other therapies that are still available for use. And in particular, I'd like to highlight azathioprine. This comes up as a drug from time to time, particularly because of its use and availability to be used safely in pregnancy. Dapsone, I think there's a lot of new information coming out about Dapsone. I think Dapsone is used quite a bit in other countries where access to things like Rituximab may be limited. And then, as I mentioned previously, mycophenolate mofetil was just applied in a very large randomized trial, even as upfront therapy. So I think there's still a lot that we're going to learn and new information coming out about the use of mycophenolate mofetil for ITP. I think that the real heart of this, though, and I hope it's been woven throughout, is what makes taking care of patients with ITP so engaging and so rewarding. And that is that it's really the process of how do we make decisions. We have our practice guidelines, as we've highlighted. They have gaps in knowledge. They're reliant on non-randomized trials. They are merely suggestions in the foundation on which we can apply care. And it's our job to really translate those back to the patients. And the guidelines really highlight this. They highlight that the choice of a second-line treatment needs to be individualized. It needs to account for patient factors. It should really involve education and shared decision-making. And how do we do that? How do we help physicians discuss these different options with patients? How do we make sure that patients are part of the decision-making process and that we're achieving the goals that the patients have for themselves? And then again, the notion that we should be thinking about delaying splenectomy, which is a little bit of a paradigm shift in our treatment from historically doing splenectomy very early on and very upfront. So in order to achieve the best treatment, we really need additional information. We need to make sure that there isn't something else that's a driver of that ITP, a secondary cause for the ITP that we should be treating. Do we know anything about predictors? What is the past history of that patient's bleeding? Are they on other medications that we need to be mindful of? What are their age and gender? As I mentioned, Rituximab seems to work particularly well, perhaps in a young adolescent female or an AYA female. And then I think really where the bulk of time is spent is what are the treatment goals? What are our goals of putting a patient on a therapy? Which therapy may achieve those goals the best? And this is what shared decision-making is all about. It's taking our evidence and our clinical experience, and it's looking at and spending time understanding our patients' values and their contextual experience, and having a very deliberate conversation that really merges the two of them together into what's considered an evidence-based patient preference decision. And ultimately, that leads to achieving the best results with our therapy.
Thanks, Cindy. Let's try applying this shared decision-making model to a couple cases. We'll start with this one. A 17-year-old male was diagnosed with ITP 6 months ago. He's responded well to steroids, but he has been unable to wean off prednisone. His platelet count is currently 18, and he's on prednisone 20 milligrams daily. He complains of fatigue, and he has been getting picked on at school because of weight gain and striae. He had to stop playing football because of his platelet count, and he wants to go back to the football team. So the patient is looking for a treatment that will allow him to play football again. He does not like the side effects of steroids at all, and he wants to get off them as soon as possible. He would prefer not to take a daily medication if he didn't have to. Which treatment do you recommend for this patient?
This case highlights so many of the important things that we learn when we listen to what our patient's story is, and really start to apply that. So, we're looking for something that for him achieves his goals. Coming off steroids is important. IVIG is just going to give us a very transient response. We're not quite at the point, I think, of thinking about a splenectomy for him. Hetrombopag doesn't really achieve his desire to not take a daily medication. And splenectomy has Rituximab has its associated side effects. So in this case, I think Rilzabrutinib is a very good drug for him. It achieves a stable platelet count. It would allow him to get back on the team. It would be potentially steroid sparing for him, but without having to rely on a daily medication.
Thanks, Cindy. Let's try another one. So this is a 28-year-old woman who was diagnosed with ITP 9 months ago. Her platelet count off of treatment is about 20. She has minimal bleeding symptoms most days, but very heavy menses. And her hematologist has been treating her with dexamethasone at the time of her periods to reduce bleeding. She is really anxious about her ITP and becomes tearful during the visit. Steroids disturb her sleep and make her irritable. And her heavy periods have caused her to limit her social interactions and her summer plans. So this patient is looking for a treatment that will cure her of ITP. She does not want to take medications on an ongoing basis if she doesn't have to. She wants to go back to her old life of frequent social activities without having to worry about bleeding or treatment side effects all the time. Which treatment do you recommend for her?
So again, another case that truly highlights discussions about health-related quality of life and the need for treatment just to have a better quality of life and to get back to our social interactions and social functions. I think the key here is listening to what she's saying about not wanting to take an ongoing medicine on a daily basis and looking for something that will cure her ITP. I think if we think in those terms, right, we instantly can think Hetrombopag, Fostamatinib, and Rilzabrutinib may not be the right therapies for her if she's looking for something that doesn't require ongoing therapy. And that lands us in, again, the Rituximab splenectomy category. And timing-wise, it's still a little early for the splenectomy, and perhaps Rituximab would be a really good agent for buying her a disease treatment-free response for some good time. That would allow her to get back to her normal daily activities and feel a little bit better about her quality of life and living with ITP.
So this is a 68-year-old man who was diagnosed with ITP 5 years ago. He is currently on Romiplastim and has wide fluctuations in his platelet count on therapy. He is also on anticoagulation for AFib, and he had an embolic stroke about a year ago. He has residual left-sided weakness from his stroke and is a fall risk. He uses a walker for ambulation. He and his cardiologist are very concerned about his risk of serious bleeding. So this patient is looking for a treatment that will achieve a safe and stable platelet count and reduce his bleeding risk and allow him to continue safely on anticoagulation. Which treatment do you recommend for this patient?
Yeah, so you can see here now how we're dealing with a very different category of patient and treatment goals, right? We're adding in now layers of comorbidities, of additional medications with a bleeding risk, additional medical conditions with a fall risk and potential for bleeding risk, a different duration of ITP and age of patient. And so I think in this patient, if we really think about what's going to give us the best long-term, durable, safe platelet count and alleviate a lot of those other concerns, in this case, it would be splenectomy, offering that kind of definitive treatment that would allow him to then have a safe long-term impact without having to worry then about all the other risk factors for bleeding that are present in this patient.
Okay, so this next case is for Hanny, a 75-year-old woman has had ITP for 30 years, so chronic disease. She has had numerous treatments in the past, including splenectomy, Rituximab, Hetrombopag, Romiplastim, Fostamatinib, and multiple other immunosuppressive agents. She has had transient responses with these treatments, but is currently requiring prednisone, 20 film 5 milligrams daily, and periodic IVIG infusions to maintain her platelet count. She asks if there are any promising treatments for ITP in development. Which of the following pathways are currently being investigated for the treatment of ITP?
Yeah, so Adam, this is a case that we get not infrequently in the clinic, right? A patient that's had ITP for quite some time has cycled through just about every therapy and lots of salvage therapies. And the question is, well, what's next? Is there something in clinical trials that might be promising for this patient? And we have a number of mechanisms here as options. And actually, the right answer is all of the above. So the development of new drugs in ITP right now is very robust, and I'm happy to take us through some of those potentially promising investigational therapies for ITP. So while we classically think of ITP as a disease of increased platelet destruction due to platelet autoantibodies, there are actually many varied aspects to the pathologic immune response that results in the clinical picture we call ITP. These include autoantibody-mediated destruction of platelets, as we certainly know, autoantibody-mediated inducement of megakaryocyte apoptosis, resulting in inadequate platelet production, in addition to that increased destruction piece, complement activation and opsonization of platelets, macrophage-mediated destruction of platelets that have been opsonized by autoantibodies and complement, and cytotoxic T cell mediated destruction of both platelets and megakaryocytes. So as you can see from this figure I have here, it provides us with many opportunities to target the various aspects of this pathophysiology. Many novel targets are currently being explored in early and late phase clinical trials. Let's talk about it. So we'll begin a discussion of novel targets and novel therapeutics by considering the neonatal Fc receptor antagonists. So the neonatal Fc receptor is a critically important receptor in determining the half-life of circulating IgG. It does this by protecting IgG from intracellular degradation, resulting in a half-life of circulating IgG of approximately 3 weeks, and therefore contributes markedly to the high plasma levels of IgG that exists at baseline. Blocking the neonatal Fc receptor then will markedly reduce the half-life of IgG down to about 7 days. Therefore, in humorally mediated autoimmune diseases like ITP, this approach can be effective. As an example, this class of drugs is already approved for and being used to treat myasthenia gravis. To consider neonatal Fc receptor antagonists or FcRn antagonists currently under development to treat ITP, Rituximab is a humanized, high-affinity, parenterally administered anti-human neonatal Fc receptor monoclonal antibody currently under development to treat ITP. In a published phase 2 study enrolling 65 patients with ITP who had a median ITP duration of 5.8 years and a median of 4 prior ITP therapies, so a heavily pre-treated population, the percentage of patients achieving a platelet response, defined in this case as a platelet count improvement to 50,000 or more, ranged between 35 and 66% of patients, depending on the dose cohort, as you can see here. Major decreases in IgG levels were observed across all dose groups, and Rituximab was well tolerated across all dose groups, with headache, diarrhea, and vomiting as the most commonly reported adverse events. Similarly, efgartigimod is another neonatal Fc receptor antagonist. It's a human IgG1 antibody Fc fragment that acts as a ligand of the FcRn, and it is engineered actually for increased affinity to the FcRn. And like Rituximab, efgartigimod, it's parenterally administered. It blocks the FcRn, preventing IgG recycling and causing targeted IgG degradation. So in a published phase 2 study, 38 adults with ITP, again, patients mostly refractory to many lines of therapy, were randomized 1:1:1 to receive 4 weekly IV infusions of either placebo or efgartigimod at a dose of 5 or 10 milligrams per kilogram. Efgartigimod induced a rapid reduction of total IgG levels, up to 63% mean reduction from baseline, which was associated with clinically relevant increases in platelet counts. 46% of patients on efgartigimod versus just 25% on placebo achieved a platelet count of greater than 50,000 on at least 2 occasions, and 38% of patients receiving efgartigimod versus 0% of patients receiving placebo achieved a platelet count of greater than 50,000 for at least 10 cumulative days. This short treatment cycle of efgartigimod was well tolerated and had a favorable safety profile. So efgartigimod already approved by the FDA for myasthenia gravis, and a recent phase 3 study just reported positive top-line data in ITP, so definitely one to keep a lookout for. Now, moving on to complement inhibition in ITP, the agent furthest along in investigation as a complement inhibitor in ITP is a drug called Sutimlimab, which is already FDA approved for cold agglutinin disease. Sutimlimab is a humanized monoclonal anti-C1s antibody that selectively inhibits the C1 complex of complement, preventing complement activation while leaving the lectin and alternative pathways intact. In doing so, patients don't lose their entire complement system, which would be a concern regarding infectious risk. In a phase 1 study of Sutimlimab and ITP, 12 adults with primarily relapsed refractory ITP were treated with Sutimlimab infusions every 2 weeks. As you can see from the figure I have here, the platelet count rapidly improves as complement functional activity rapidly drops after the very first infusion. Remarkably, meaningful platelet count improvements were actually observed in some patients within just 4 to 8 hours of the first Sutimlimab infusion. You can see that as treatment stops in this Part A washout, the platelet count plummets again and complement activity recovers. And once Sutimlimab is restarted, the treatment effect is recovered. So in this small phase 1 study, 42% of patients achieved an overall response, and this response was also durable with continued Sutimlimab treatment, and the drug was well tolerated overall. Moving on to thrombopoietin receptor agonists. So we already have 3 thrombopoietin receptor agonists approved for ITP, Remiplastim, L-Trombopag, and Avatrombopag, and a 4th, Lusutrombopag, approved for thrombocytopenia in patients with chronic liver disease undergoing a procedure. There is a new agent currently in development called Hetrombopag. So this is an oral thrombopoietin receptor agonist that's been demonstrated in a large trial to be efficacious in patients with ITP at doses of 2.5 and 5 milligrams compared to placebo, as you can see here, with a reasonable safety profile. Like L-Trombopag, Hetrombopag appears to have relevant food interactions with absorption reduced when taken with certain foods. So a new up-and-coming thrombopoietin receptor agonist. Moving on to another class. So inhibitors of the Bruton's tyrosine kinase, or BTK, are commonly employed to treat lymphoid malignancies, as we know, after it was recognized that patients with non-Hodgkin lymphomas and ITP treated with ibrutinib had high rates of ITP remission. Interest was really piqued in evaluating this class of drugs to treat ITP, as multiple pathophysiologic mechanisms can be targeted simultaneously. Rilzabrutinib is a highly selective inhibitor of the Bruton's tyrosine kinase that's been evaluated in a phase 1-2 study in patients with chronic ITP. 60 patients were enrolled. At baseline, the median platelet count was only 15,000. Median duration of disease was quite long at 6.3 years, and patients had received a median of 4 different ITP therapies prior to Rilzabrutinib. Despite having generally quite refractory disease, 24 of 60 patients, or 40% overall, and 18 of the 45 patients who had started Rilzabrutinib at the highest dose in the study met the primary endpoint of a platelet response. The median time to the first platelet count of at least 50,000 was 11.5 days. So, many immune modulatory agents in ITP may take longer times to work, and the median time with this study was just 11 and a half days. Among patients with a primary platelet response, the mean percentage of weeks with a platelet count of at least 50,000 was 65%. And of course, importantly, Rilzabrutinib was well tolerated. All the treatment-related adverse events were grade 1 or grade 2, and they were transient. No treatment-related bleeding or thrombotic events of grade 2 or higher were observed. Very interestingly, and unlike most other agents, that patients' treatment history didn't really seem to matter too much, with similar response rates in all the various subgroups examined. Of course, it's not known what the response rate would be if used earlier in the disease course rather than a median of 6+ years into the disease. You may be wondering, BTK inhibitors and ITP, but BTK inhibitors inhibit platelet function, right? So certainly ibrutinib does. So why would we use a BTK inhibitor to treat ITP? Well, Rilzabrutinib, as it turns out, is considerably more selective than ibrutinib, which has those known platelet inhibitory effects. And this selectivity means that platelet aggregation in subjects receiving Rilzabrutinib does not appear to be impacted, in clear contrast to ibrutinib, as you can see from these figures demonstrating the impact of each drug on aggregation to various agonists as assessed by light transmission platelet aggregometry. So we see here that the healthy volunteers and the ITP patients receiving Rilzabrutinib really have preserved platelet function. So in conclusion, guidelines exist to provide a foundation for the care of patients with ITP needing second-line therapy. There is a lack of high-quality evidence to provide strong recommendations. Physicians should engage in shared decision-making to optimize the treatment plan and achieve meaningful patient-related goals. And there are newer therapies in development that may have benefits for those patients with refractory disease. I'd like to thank the supporters of this educational program, Novartis, UCB, Argenx, and Amgen.